Good afternoon, everyone, and welcome to ACHA's webinar, Coronavirus and the CHD Patient. I'm really pleased and excited to see so many of you here tonight. Because of our overwhelming response, welcome to ACHA's webinar. Our overwhelming response, we are streaming live on YouTube today. My name is Paula Miller, and I'm the Senior Education Manager at ACHA. I will be moderating tonight's webinar. If you have any questions during the course of the presentation, please send them to me, the moderator, by clicking on the Questions and Answers tab at the top of your control panel and type in your question. With the record-breaking number of attendees right at 3,000, we will only be able to answer a very limited number of questions during today's Q&A. The speakers will not make individual treatment recommendations as they do not know your own personal situation. But if you have individual medical questions specific to you and your congenital heart disease, you should reach out to your ACHD care team on the CDC or the CDC. Please note that the webinar is also being recorded so you can watch it again at any time. Our speakers tonight are Dr. Aric Gregson and Dr. Jamil Aboulhosn. Dr. Gregson is an infectious disease specialist in the Los Angeles area. He specializes in immunocompromised patients and has treated recently cases of COVID-19 in Southern California. Dr. Jamil Aboulhosn is chair of the ACHA Medical Advisory Board and is the director of the Ahmanson UCLA Adult Congenital Heart Center. Dr. Aboulhosn is on the writing committee for the American College of Cardiology and American Heart Association guidelines of on adult congenital heart disease. He also serves on the ACHA Program Accreditation Steering Committee. So it is now my privilege and pleasure to first introduce Dr. Aric Gregson. Dr. Gregson?
Thank you very much for that wonderful introduction, and I'm extremely happy and pleased to be here presenting, and it's fantastic, the turnout that we have, and we do hope to be able to answer some questions at the end, so write them down. Okay, so I would like to start with, actually it looks like we have a little change here. Follow up. So what is a coronavirus? Well, clearly, coronavirus is a virus. And I wanted to start very simply to understand what the coronavirus is and where it came from. And what is a virus after all? Well, a virus is a very tiny infectious agent that only grows and can only expand and transmit after growth within the cell of another organism. They're almost like parasites of cells on a cellular level. And all forms of life have viruses. All animals, plants, parasites, fungi, and bacteria, they all have viruses. So there are millions of different viruses in the environment. The first discovered was something called tobacco mosaic virus, and that was in 1898. And as you might guess, it infects the tobacco plant. Now we have about 5,000 very well-described viruses that we know about. Viruses include organisms that we know very well, such as seasonal influenza, HIV, measles, we've heard a lot about lately, herpes simplex, a very common cause of cold sores, and hepatitis C, which you've probably seen advertised on TV, no doubt. But viruses are categorized by the type of nucleic acid in their genome, either RNA or DNA, and this is what directs the host cell to produce more viruses that can then leave that cell and go on and infect more cells. And I just want to point out, and it's very important to remember, viruses are not killed by antibiotics. Antibiotics target bacteria, and these have no effect on the viruses. To kill viruses, we need specific antiviral medications. So what are coronaviruses? Well, obviously they're a virus, but there are many different kinds of coronaviruses. The vast majority of these cause disease in humans and animals that produce a common cold-type syndrome. And we're all familiar with this. This is a runny nose, malaise, usually a non-productive cough at first, these sorts of symptoms. Well, what makes coronaviruses a bit more unique is that they're easily transmitted across species. So some examples of this that we probably have been thinking about lately include SARS, the original pandemic coronavirus, MERS, which went from bats to camels to humans, and now SARS coronavirus 2, which we think came from bat and through perhaps the same palm civet to humans. And here's a diagram that kind of explains this a little bit more. So if you look to the left, there's coronavirus that circulates naturally within the bat population. At some point, more than 30 years ago or so, there was some cross-species transmission between bats and camels in the Arabian Peninsula. The coronavirus adapted to its new host, the camel, and circulated within the camel population. The camel handlers, humans, were infected intermittently with coronavirus. Now, this is called a zoonotic transmission when it passes from an animal to a human. And it turns out that this happened nearly continuously, as many of the handlers are seropositive, that is, they demonstrate prior exposure to the virus through blood testing. Very few of them would get sick, though. But when they did and they were ill, they would be hospitalized with a severe pneumonia. And at that point, what could happen and did happen was something called nosocomial transmission. This is when patients that are in the hospital or hospital staff are sick and pass their disease on to other patients in the hospital or to hospital staff. And this happened with MERS, and it spread through hospitals. These people also spread into the community, and there were community contacts that also developed MERS. So this happens. What happened in about 2002 is that in China, the bat population coronavirus spread into what's called a palm civet and some other small animals that were traded at live animal markets. And then it rarely occurred that this coronavirus passed to humans in the markets, again, another zoonotic transmission. These persons went on to infect others in the community with what was called SARS then, and the same thing happened within hospitals. That was spread within hospitals. So with this new coronavirus, we think the same thing or something very similar to what happened with the SARS coronavirus is occurring now. So where did this one come from? Again, we think it's from the bats. It is related to a bat coronavirus, and this coronavirus infects what's called the horseshoe bat, and there's a picture of it there. Then again, these have the ability for pandemic spread, and we think it did probably emerge from food markets in China in November, and probably the palm civet again was the source, but that's yet to be confirmed. And here's a picture of the palm civet. So what's in a name? I don't know. It's been a bit confusing, I think, over time here. The name keeps changing. And so the World Health Organization tried to basically standardize the use of the names. So initially it was called the 2019 novel coronavirus, or 2009-nCoV for novel corona. Now the virus itself is called SARS-CoV for corona-2 for the second SARS coronavirus. This is the name of the actual virus now. COVID-19, which we're seeing a lot in the press, is the name of the disease caused by the virus, or the syndrome or constellation of symptoms and clinical findings that the virus causes. Sort of like HIV is the virus name and AIDS is the syndrome that's caused by infection with the virus. So how is this spread? We want to see, but it won't. Sorry. It doesn't want to go to that slide. So how is coronavirus transmitted? I think this is really important, and it does not want to stay on that slide. There's basically two ways to transmit a virus. So there's well, the ways that we're, oh boy, there we go. So we have airborne spread and droplet spread. So it turns out the coronavirus, like this coronavirus, like most coronaviruses, is spread through a droplet transmission. So droplet transmission means that basically they're larger particles that come from the mouth, and they tend not to travel very far, and that's because they're very large. So that compared to smaller particles, they're heavy, they fall to the ground sooner. So in normal conversation, it's usually about 3 feet. Somebody who's breathing a little heavier or sneezes, it can be up to 6 or 9 feet. This is very unlike measles or tuberculosis, where it's caused by what's called airborne spread. Now, these are very light, small particles, and they can travel up to 100 feet or more because they're caught into the air. They don't fall to the ground very quickly. So this all plays into how transmissible is the virus. Droplet spread viruses are a lot less transmissible than airborne spread, and this is actually very helpful for us trying to control the viral spread. So how do you assess the infectiousness of a virus? Well, what we use is something called reproduction number, or R naught, R to the 0. So this is a comparison of some common viruses you might know, more contagious to the right, hepatitis C, Ebola, HIV, etc. So this refers to the average number of cases that are transmitted by one infected person. Sorry, the slides keep moving. So we can see that here, COVID is somewhere around 2 to 3, we think, transmissions. 1.5 to 3.5 are not. So that means that each person with the SARS coronavirus may infect up to 3.5 people, maybe as little as 1.5. And you can see, compared to other common viruses that we have about us, that's on the lower end, particularly compared to measles, which we've heard of spreading so quickly even within vaccinated populations last year, norovirus, which is infamous for causing massive outbreaks on cruise ships. And you can see this also. So this is the R naught is on the bottom X graph, and on the sides to the left you see the percent who die, which is case fatality rate, which we'll talk about in a few minutes. And you can see COVID-19 is somewhere around 0.7 to 3.5% case fatality rate, and that compares somewhere around the Spanish flu. It's a lot less than the prior SARS coronavirus, but it is significantly higher than seasonal influenza. Okay, the controls don't seem to. Okay, so yeah, sorry. Okay, so what we're going to talk about is the controls are very difficult. But so what is the incubation period? I'm trying. I don't know what's going on here. So the incubation period is how long does it take for a coronavirus to cause symptoms after the time of exposure? So if you look on the left, panel A demonstrates, Paula, it might be better if you control the slides. My computer is not wanting to play nice with me. Maybe you can jump in. Thank you, and go back. Stop, one down. One more. There you go. Perfect. Okay, go up to incubation period. Okay, so incubation period. So on frame A, you can see the days from exposure to illness. That's the incubation period. And essentially, by day 9, nearly everyone who's been exposed starts to have symptoms, if they're going to have symptoms. And within 12 days, nearly everyone had symptoms. Now, this information is from China outbreak, so it might be a little bit different as this progresses about the world. Panel B is the days from onset of illness to the first medical visit. And you can see that most people, when they become ill, seek treatment or at least confidence in a physician or medical care by day 4. C is about the same thing. This is days of illness to hospitalization. You can see that if people were hospitalized, nearly all of them were hospitalized within the first week of illness onset. Okay, advance, please. Okay, so what are the symptoms of coronavirus or COVID-19? This is taken from China. This is reported up to February 22nd, so this also may change slightly, but essentially almost everyone develops fever. The vast majority of them have a dry cough. What is a dry cough? A dry cough is a cough that's not terribly productive of sputum. Most also feel fatigue. About a third of them do have sputum production, and about 20% or 1 in 5 have some shortness of breath. Now, a smaller number have muscle pains and joint pains, sore throats and headaches. And chills, which is somewhat similar to flu that we all experience, the seasonal flu. However, very few people have nasal congestion, and diarrhea is uncommon. So the presentation with nasal congestion and fever would more likely point to a common cold coronavirus rather than the COVID-19 presentation. Advance. Thank you. So I want to point out that, despite everything we're hearing, the vast majority of these infections are mild. Over 80% of the symptoms thus far, or cases in mainland China, were mild. That meant like a mild flu, people were able to stay at home. A small number, less than 20%, less than 1 in 5, had enough of symptomatology to warrant hospitalization, and a few patients ended up in the intensive care unit with a very severe disease. I'll pass on. Okay, so again, who's most at risk, though? And this is, I love this slide. I think it really demonstrates very well the size of the blocks show your risk, and it's mostly based on age. So those over 60 years of old are definitely at a much higher risk than those under 60 years of age, and you can see that this risk increases with increasing age. So an 80-year-old, most of the cases, almost 20% were in 80-plus-year-olds, another 10% in 70s to 80s. And you can look down, you can barely even see the risk for those less than 30 is very small. Less than 1% of the total cases are in patients under the age of 20. Go ahead and advance. So again, those at risk, especially those older and those with existing conditions. So cardiovascular disease is considered a risk, and you can see that about 1 in 10 of patients with serious diseases, serious infection, and ultimately ended up dying had cardiovascular disease. The next highest risk was diabetes and chronic respiratory disease. In a multivariate analysis, though, the only things that were actually important were age and cardiovascular disease. And again, it's mostly older people. Okay, advance. So I want to talk about case fatality rate versus mortality rate. This is something that I think has been talked about in the press a bit. So what is case fatality rate and what is mortality rate? Well, mortality rate is the deaths per unit time, usually measured as 1 year, in the total population. So that would be like the total population of the United States, the deaths per unit time of 1 year. The case fatality rate is the number of deaths in an affected population, in other words, in the sick population. So the case fatality rate is the number of deaths out of the people that are actually sick with the illness. Okay, advance. And this illustrates my point here that this is a very important thing to understand, because the case fatality rate depends very heavily on how many people are tested and diagnosed with a particular illness. The fewer people that are tested and diagnosed, the higher the case fatality is going to look. So if you look here, this shows the population on the right and the tests per million people on the left. And you can see that our tests per million people is extremely low, one of the lowest in the world, whereas South Korea has a very high ratio test per million people versus their population. And it's important to note that South Korea has reported a case fatality rate of less than 1%, and that is probably due to their widespread testing, and they've diagnosed a good number of patients per their population. Advance. So the case fatality rate does vary by country, and again, some of that has to do with the diagnosis of cases, like in our case, the United States, and other of it has to do with the population that's affected, perhaps Italy, and also the resources that a country can bear to bring to the crisis. And again, I think that shows that Italy is struggling with this at the moment. But you can see the average case fatality rate is 1.5%, and I suspect that will continue to fall as more and more cases are actually diagnosed. Okay, advance. Okay, and then I just wanted to kind of put this into somewhat of a perspective with the average disease deaths per day worldwide. Right now, coronavirus is probably running around 70, perhaps a little higher now. As this new information comes, this will likely change. But compared to even rabies, there's more deaths of rabies around the world every day. This is per day, and even the norovirus, which to us is a burden on cruise ships, but it actually is fatal, particularly for children. And then you look down at MERS. I mean, the SARS and MERS outbreaks previously, which didn't get as large as this present coronavirus, but ended up being about 2 to 3 deaths per day. So advance. So what can you do? Well, some of the suggestions that the CDC has for us as persons that we can do is to wash our hands often with soap and water for at least 20 seconds. This is especially after blowing your nose, coughing, or sneezing. Why is that? Well, the droplets that you cough out that contain the virus land on your hands, and if you don't wash them off, you can spread those to other surfaces like handrails, elevator buttons, etc. So washing your hands will prevent spread if you have the virus. Clearly, after going to the bathroom, washing your hands, and before eating or preparing food. And again, for the same reason, if you have viral particles on your hands, you might be then contaminating the food that you eat and touch. And again, avoid touching your eyes, nose, and mouth with unwashed hands. And I think most importantly, stay at home when you're sick. This is a good advice anytime, but in the pandemic situation, not only are people around you hyper alert to somebody that's sick, it's just not really fair to those about you to head out if you're sick, particularly if you don't know what you're ill from. And if you are out, please do cover your cough or sneeze with either your arm or something, whether it's a tissue or not, I don't know. But advance. And the CDC has recommended for social occasions for the next 8 weeks that organizers, groups or individuals cancel and postpone in-person events, 50 or more people throughout the United States. And states are taking this differently, and cities are handling this differently across the United States. And this will certainly change as more information becomes available. And I want to, the next slide, I want to talk about something that's been going on. They talk about flattening the curve. And I'm not sure if everyone knows what that means, but this is a representation of what an outbreak may look like. On the left, the y-axis, we see the daily number of cases. So this is how many people are diagnosed each day. And on the bottom of the x-axis, we see the time, so the time since the outbreak. So if you look at where the two lines come together, we have the beginning of the outbreak. And what happens is over time, the yellow increases as more people are diagnosed, and there's a blue line you see going across. This is called the capacity of the healthcare system, and this is what we're most concerned about right now, is the capacity of our healthcare system to take care of sick patients who actually need to be admitted. So what we'd like to do is keep the outbreak from turning into the yellow plot and instead into the purple distribution, and that's called flattening the curve. And what you're doing, you are hopefully reducing the number of infections, but more importantly, you're slowing the outbreak down. So instead of having a massive influx of persons that overwhelms the capacity of the healthcare system, as has happened in Italy, we can slow down the spread. And although we will have people being admitted to the hospital, we hope to keep the numbers down to more a constant rate where the healthcare system can manage the outbreak and we not run out of supplies such as beds and other supplies that are needed. So these social measures that are being proposed by the CDC and our local governments are meant to flatten the curve, which means to slow down the outbreak and keep the virus from overwhelming the healthcare system. So with that, I thank you, and I'd like to turn the presentation over to Dr. Jamil Aboulhosn.
Great. Thank you, Dr. Gregson. If you don't mind, Paula, going to my presentation. So I've been keeping an eye on all the questions that are coming in. We're up to about 84, 85 questions. So as I go through my talk here, I will try to hopefully touch upon some of the themes that were being asked about, with the understanding here that we, at this point, don't have any CHD-specific data that we can share with you. That is not, the data out of China and South Korea and Italy is not granular enough at this point when it comes to the types of cardiovascular disease. But I will talk about the interaction of COVID-19 with the cardiovascular system and the cardiovascular considerations that we should have. So Paula, if you don't mind giving me control, I can go forward. Okay, great. So how does the novel coronavirus affect the heart? All right, here we go. Okay, so there's an enzyme called angiotensin converting enzyme 2, ACE2. And this is a membrane-bound aminopeptidase that has a vital role in the cardiovascular system. And there's a diagram here that kind of helps you understand this would be a human cell, mostly in the lungs and in the heart. That's where it is found. And the coronavirus, and corona refers to these spike proteins here that will attach to the ACE2 receptor. ACE2 is involved in heart function, normal heart function, and also in the development of hypertension and diabetes mellitus. So those that have hypertension and diabetes will have an overexpression of this particular receptor. In addition, ACE2 has now been identified as a functional receptor for the coronavirus in both the heart and the lungs. Infection is triggered by binding of the spike protein of the virus to ACE2, which is highly expressed in the heart and lungs. Now, many of the questions that are being asked are specific to, hey, I'm on an angiotensin converting enzyme inhibitor, an ACE inhibitor, very commonly used antihypertensive drug, also a drug class that is often used in patients with heart failure, low ejection fractions, valvular heart disease. Does that mean that I need to stop my angiotensin converting enzyme inhibitor at this point? The reality of it is we don't have enough evidence to go recommending at this point that you should be stopping or changing your cardiac medications. But stay tuned, because if we do get some evidence to suggest that, then you will get recommendations from the American College of Cardiology. Your cardiologists will to do so. The other class of agents that affects the amount of ACE2 receptor are angiotensin receptor blocker medications like losartan or valsartan or telmisartan. So what role those may have, either protective or otherwise, is still yet to be elucidated. So we do not have the answer to that. We will go over what data we do have, but frankly, we will not be making any specific recommendations like that unless they are truly supported by evidence and by the CDC recommendations. But certainly we do encourage you to speak to your providers about this as well, and stay tuned. Clinical symptoms of COVID-2. So fever, very common in the majority of patients. Cough, again, very common in most patients. Myalgia or fatigue, muscle pains or fatigue, less common, but certainly present. Shortness of breath in about a third of patients. less common symptoms, as Dr. Gregson described here, diarrhea, a productive cough where you're bringing up yellowish or greenish sputum is less likely with just the COVID infection. However, if someone has a bacterial superinfection, and what I mean by that is that these viral infections can cause enough damage to the lung tissue where now bacteria find it easier to cause a superinfection. So if a dry cough converts to a wet cough that is productive, that may mean that someone has a bacterial superinfection and should be treated for that. Potential worsening of the clinical course during the second week of symptoms, and we'll go over as to why that could potentially be happening here. ARDS, this is an acute and severe lung injury, and it can develop in up to 1/3 of hospitalized patients. And this is the type of lung injury that may require that patients end up getting mechanical ventilation. So that is something that is being seen in the severest of cases on X-ray and CT scan. Secondary infection, which I mentioned a little bit earlier, and this is in the Chinese experience, occurs in about 10% of hospitalized patients. And this is where antibacterial medications, typical antibiotics, may need to be used and often are used because of the possibility of a combined infection. So let's talk a little bit about what we know about cardiac disease and COVID-19. So this virus, the SARS-CoV-2, mainly invades in the lung alveolar epithelial cells. These are the cells within the air sacs of the lungs, and that's what results in the respiratory symptoms. These symptoms are more severe in patients with cardiovascular disease. Now, I'm going to stop for a moment here, and again, to maybe answer some of the questions that are being asked about the what is meant by cardiovascular disease in these studies. Is this referring to congenital heart disease? The vast majority of the patients that are described in the Chinese experience, which is the one that we know the most about here, and there's been the most publications on, are patients who have coronary heart disease, are older, have hypertension, and have what we would call acquired heart disease. So that does not mean that patients with congenital heart disease are not going to be at risk, but just realize that when this is being talked about, the vast majority of these patients are older patients with acquired types of heart disease, not patients with congenital heart disease. So these symptoms are more severe in patients with this kind of cardiovascular disease, which might be associated with an increased secretion of ACE2 in these patients compared with healthy individuals. In the Wuhan experience, some patients have presented with heart palpitations, shortness of breath, and chest tightness rather than fever and cough. And they were later diagnosed with COVID-19. So, those are the minority of patients, but, that is a possibility that someone may not have a classic presentation, but may present purely with cardiovascular symptoms. Again, very rare, but not unheard of. Among the patients with severe symptoms of COVID-19, about 60%, 58% had hypertension, and this is not pulmonary hypertension. This is referring to systemic hypertension, high blood pressure. 25% had known heart disease, the majority likely being coronary heart disease, not congenital heart disease, and 44% of patients had arrhythmias. Certainly, this is a concern in our population. Patients with congenital heart disease, especially those with more complex forms of congenital heart disease who've had more surgeries, are more likely to have arrhythmias. So we would be concerned about the arrhythmia risk in our population and that being less stable during a COVID infection. According to mortality data from the Chinese Health Service, 35% of patients with SARS-CoV-2 infection had a history of hypertension, and another 17% had a history of coronary heart disease. I'll go on to the next slide. Oh, sorry, 1 second here. And really, at this point, we have no data available as of yet specific to congenital heart disease patients or adult congenital heart disease patients. Now, one thing we will plan on doing through the Adult Congenital Heart Disease or Adult Congenital Heart Association and through the accreditation program is to try and gather data as quickly as possible specific to our ACHD patients. So as we see cases, we will hopefully be keeping track of those cases and essentially building a much needed database so we can give you more specific answers regarding CHD and ACHD. But as of yet, we do not have any data that is specific to ACHD and CHD patients. So mechanisms of cardiac injury in COVID-19. So we're talking about basically three likely mechanisms. So one is direct cell damage by the virus, and this is likely through that ACE2 mechanism. We know that this is happening within the lungs, and in those patients who do develop cardiomyopathies, it appears that this is a likely mechanism as well. Second possible mechanism is a pro-inflammatory cytokine surge as a result of the viral infection. And this is a person's own immune system responding to the presence of this virus. Typically, this is a little bit delayed, not early on in the course of the viral infection, but can result in a severe inflammatory response that affects multiple areas, but most prominently the lungs and the heart. The lungs more so, however. And that and compromise to those organs could then lead to other organ dysfunction. And then the third mechanism is a mechanism related to lung injury and a problem now with oxygenation. If somebody is not able to oxygenate appropriately because of the lung injury from either mechanism number 1 or mechanism number 2, and they have a heart that is compromised in some way, for example, somebody who has multivessel coronary disease or has congestive heart failure, well, then they're not going to have as much reserve to deal with the low oxygen levels resulting from the lung injury, and they are going to be at higher risk for congestive heart failure and for arrhythmias and other cardiac complications. So I worry that in patients with congenital heart disease that this mechanism number 3, especially in those that have already compromised cardiovascular systems and are already symptomatic of volume overload heart failure, already having arrhythmias, that an additional viral infection can worsen those things. But that we do see, frankly, during every flu season. So this is a mechanism that we see on a yearly basis whenever these kinds of viral outbreaks occur in our population. As far as congenital heart disease patients being more at risk for mechanism number 1 or number 2, frankly, that is left to be determined. We have not had any reports as of yet that is the case. There is an additional factor here that we should consider, which is the younger age of most patients with congenital heart disease. As Dr. Gregson showed, the highest risk patients are those that are significantly older, right? Older than 60 and even above 80 years of age. Most of our patients are not going to be in that category. Some will be. So does that provide some protection? We will have to see. So this is from the Wuhan experience published in JAMA in February, and this is looking at total number. And if you see, I sort of tried to focus here on acute cardiac injury and arrhythmias, but certainly there's a lot of other information in this table here. But let's start with acute cardiac injury. How do we define acute cardiac injury? That's an elevation in circulating cardiac enzyme levels. We call those troponin levels, which is what's often found when somebody has a heart attack or when somebody has heart muscle injury. And if you look at all comers in this population of 138 patients, about 7% actually had evidence of acute cardiac injury. But now if you look at patients that ended up in the intensive care unit, so the sickest patients, well, almost a quarter of those ended up having acute cardiac injury, versus the ones that did not end up in an ICU, only 2% had acute cardiac injury. So, it's a question of, is it the chicken or is it the egg? Did the acute cardiac injury end them up in the ICU, or did they have cardiac injury because they are so sick and required ICU care? Difficult to parse out from the data we've been provided, but certainly we would expect, even outside of COVID-19 here, patients with viral conditions that do end up in the intensive care unit tend to have more cardiac injury anyway. Arrhythmias. So about 17% of all comers in this series had arrhythmias, but again, the same kind of pattern holds. Almost half of the patients who were hospitalized in the ICU ended up having some form of arrhythmia. And I'm assuming in an older patient population that the majority of these would have been atrial fibrillation. But certainly this is an area that I would be concerned about when it comes to our congenital heart disease patients who are already at risk for arrhythmias, the possibility of patients having more arrhythmias when they have the COVID infection. Non-ICU patients, about 7% of these had arrhythmias. And if you look at some of these other things, ARDS, acute kidney injury, that's AKI is acute kidney injury, again, higher numbers in the ICU patients, ARDS in 61% of ICU patients versus only 5% of non-ICU patients. And then shock occurring in about a third of those that ended up in the ICU versus only 1% of those that did not end up in the ICU. So, the folks that do get very sick from this disease do get extremely sick, and that is certainly what's playing out here. But the majority of patients, as mentioned by Dr. Gregson, do not seem to get that ill at all and have mild symptoms. So let's go on. Oh, somehow my slides ended up. Paula, would you mind giving me the control back here so I can? All right, sorry about that. One sec, folks. Okay, so I'm going to just go back one, make sure I'm on the right slide here. Would you mind giving me control back? Or could you go one slide back then? Okay, would you mind going one slide back, please? Well, let me just go over this.
It's showing you have had control. I can do it now if you need me to. I just gave it back.
Yeah, please go back. Please go back one slide. Okay, great. Now go one full.
Okay, there.
Great. Okay. So let's talk about testing a little bit. There's been a lot of hype and concern and frankly, a lot going on when it comes to reports about testing availability, no testing availability, et cetera. Here's the bottom line as far as we can tell. PCR, which is the test that is used to detect the virus, seems to have a sensitivity somewhere on the order of 75%. So among patients with suspected COVID-19, and an initial negative PCR, repeat PCR was positive in about 23% of patients with very suggestive symptoms. This suggests now that the PCR sensitivity is well below 80%, and that there is that likelihood of conversion from a negative test to a positive test within a period of days. Often these patients are having CT scans that show disease progression well before PCR positivity. So yes, testing is important. Yes, we should have a lot more testing available, but even with testing, we could be missing up to about 25% of cases that may then later become positive. So a single negative PCR test does not completely exclude COVID-19, especially if it is obtained from a nasal source or if taken relatively early in the disease course. And this is, again, from the Chinese experience. If the RT-PCR is negative, but there's suspicion for COVID-19 remaining, then we have been recommending ongoing isolation and resampling several days later, and that should be considered. So some issues there with the testing. Do we need the testing? Yes. But is it a panacea? Is it something that will detect every single case? The answer is no. Next slide, please. So stages of the illness. So there seem to be different stages of this illness that patients may move through. And I'll try to break it down into basically two major stages here. The first is replicative stage. And this is where viral replication occurs over a period of several days. We all have innate immunity, and that innate immune response occurs, but this response, because we have not seen this virus before, fails to contain the virus. But we have relatively mild symptoms at that point. Those can occur due to the direct viral effects on our body and also the innate immune response that we have. But at this point, we have not manifested yet a very strong immune response. The second stage is adaptive immunity. And at this point, this eventually kicks into gear, and this leads to falling titers of virus. However, it may also increase the levels of inflammation, these inflammatory cytokines, and that leads to further tissue damage, and that can cause clinical deterioration. And this is that kind of concerning pattern that has been noted in the patients that become sickest, which is that patients seem to have relatively mild symptoms. It goes on for a week or maybe longer. They look like they're getting better. They may be turning the corner, and then they get extremely sick. And so that is that number two kicking in there with very high inflammatory cytokine levels. And that could potentially be the explanation for what we're seeing. Next slide, please. So this is an example of a very severe case. And again, I just want to tell everybody and reiterate that the vast majority of cases are not severe. Okay, the vast majority of cases are not severe. But this is an example of a very severe case going through those various stages, right, of innate and then adaptive immunity. 50-year-old man admitted with a fever, chills, begins improving at about day 8, and then day 12 worsens, and within 2 days ends up in the ICU and has a cardiac arrest and ends up intubated before that as well. And that is the course that is being described for the very sickest patients. Are congenital heart disease patients at higher risk for this? We don't know. We do not know that answer. I see it being asked over and over, and very specific congenital heart disease subtypes, et cetera. There's no way I can answer that, or Dr. Gregson or anybody actually in the world can answer that right now. We need more data to see how CHD patients fare when it comes to these stages. Next, please. So again, looking at this, 81% of cases are mild. What does that mean? Mild cases include all patients who do not have a pneumonia or those that have a very mild pneumonia, not requiring oxygen, et cetera. 14% of cases are more severe, and severe cases include patients who suffer from shortness of breath, respiratory frequency. That means where you're breathing more than 30 times a minute. That's pretty fast. That's somebody just really huffing and puffing. Blood oxygen levels below 93%. Now, there are probably many people on the call who have resting oxygen levels that are well below 93%. So this does not, it doesn't mean all of a sudden you're a severe case of COVID-19. If you live with an oxygen saturation of 85%, you are going to be unique. So these don't necessarily apply to you. But for those that have completely normal oxygenation, a drop in blood oxygen saturation less than 93% does portend that this is now a severe case. And then lung infiltrates seen on X-ray and CT scan. And then 5% of cases are considered critical cases. And these include patients who suffer respiratory failure, septic shock, multi-organ dysfunction, heart failure requiring the use of ECMO, which is a means of basically supporting the circulation. Those would be considered critical cases. The concerning thing here is about half of critical cases have resulted in death. And this is not just from the Chinese experience, but also now the data that's beginning to come out of Italy suggests that as well. Forward, please. Mortality rates here according to age. Now, again, I've seen questions, at least back when it was still at about 85 or 90 questions. Now it's at 221. So sorry, I haven't looked at the questions while I'm speaking. But you can see here that the case mortality rates are quite low in young children. And we do not know if this is going to be any different for children with congenital heart disease. But again, no news, I guess, at this point is still good news because we have not heard of that yet. Almost certainly, if this pandemic continues to spread, and we expect that it will, that we are going to be hearing about cases there as well. But as of yet, it appears that of confirmed cases, the risk is much lower in young children than it is in much older patients. So you can see there the risk of those that are over 80 years of age approaches 15% mortality. Next, please. So comorbidities here. And can you click the button one more time if you don't mind? I have a pop-up as well here. Okay, there we go. So case fatality rates for comorbid conditions. That means patients that have other conditions, and how do those other conditions potentially affect their risk of mortality when they get this virus. So cancer, and if you take that baseline background rate of 2.3%, as being the baseline, so cancer increases that about twofold, up to 5.6%. Having hypertension, you go up to 6%. Chronic respiratory diseases, and the majority of these we're talking about would be emphysema, smokers and such, 6.3%. Diabetics, 7.3%. There was a question that I saw about uncontrolled versus controlled diabetes. Certainly it makes sense that those with controlled diabetes under good blood sugar control would have a lower risk, but the data that we have is not granular enough for me to be able to make that statement convincingly. But it does make sense. And then cardiovascular disease, you can see there, it's concerning that that certainly is a significantly higher risk, 10.5% mortality rate. But again, that is in majority of patients having acquired heart disease, coronary disease, and being older patients. So applying this to our CHD patient population is a little bit difficult here. Next, please. Okay, do you see my mouse at all? Paula, do you see it at all? I want to point to.
No, I can't see your mouse, but if you tell me where I can put my mouse up.
Yeah, can you give me control, and I just need to show people.
It's showing you have control. I can't. It's showing you have control, and waiting for you to control your screen. There's something on here that's
no problem.
not right. I'm
no
sorry.
Problem. Okay, no problem. So cumulative case numbers. Let's go back to you controlling it then. So cumulative case numbers here. Since after the 100th case was identified. And this is looking at, this is basically from the end of last week and looking at cumulative case numbers around the world. And this is why these draconian measures of isolation and quarantining and a strong community response are so important. Because look at Hong Kong and Singapore, okay? Hong Kong, rapid school closures, quarantining, strong community response. Okay, Hong Kong is, I mean, many of you have probably been to Hong Kong or at least have seen it, very built up city, lots of population density, low rates in Hong Kong because of a very strong and almost immediate response. Singapore, very strict quarantine rules, rigorous contact tracing, again, low rates. Japan, lower rates than what we're seeing. South Korea, spread was slowed from the initial pace, but there was an outbreak in Seoul that picked it up again. But you can see that South Korea looks like it's flattening out. Italy is still on its way up. We are quite concerned about the United States. So if you look at the red line there, and you can see the trajectory of the United States, and we're now well over 2,000 cases. That is, please go back if you don't mind. That is going up exponentially. This is why these draconian measures that are being suggested by the CDC and, for example, I live in California, by the governor of California. In Los Angeles, restaurants are closed, bars are closed, theaters are closed now. People are being asked not to gather, etc. It is to slow down this spread. So we need everybody signed on to this as much as possible in as reasonable a way as possible, obviously, in order to decrease the logarithmic increase in cases here. Next, please. There is good news here when we look at China, right? So look at China versus the rest of the world, and this is as of March 12th, and this has continued to be the case. So we see the sort of exponential rise in January into early February, and then we see a flattening of that curve in overall cases in China, and that's continued to be the case, and now possibly starting to go down. And we see that those mortality rates are following the same trend as the overall case rates. Now, if you look at the rest of the world, we're still on that sort of upsloping portion of the curve at this point. So hopefully within the next month or two, we will see a leveling off of that curve, and if you don't mind clicking the button twice there, just to show where we're trying to go, we are trying to level those two curves for the rest of the world. But the fact that this is happening in China suggests that this can happen elsewhere as well, and that this hopefully will be the trend that we will see in the United States. Next, please. So in the absence of any proven treatment at this point, and I am not going to, neither Dr. Gregson nor I will discuss at this point some of the possible treatments out there like antiretrovirals, chloroquine, that may be showing some promise. And the reason for that, you guys, is that the reality of it is that's still all in testing and in the trial phase. So we really cannot be making any recommendations as far as antiviral treatments at this point. And the vaccines, we have heard, are going to be many months away at the soonest. So this is what we need to do now. What we need to do is we need to ensure that we have lower case rates, total new cases, so that we do not overwhelm our ICU beds at our treating facilities. So let's start with the largest curve there, which is total new cases if we have no containment policy. Okay, so if we just all went about our business, had no containment, we would have this early and very high spike. Now, most of those cases, as I said, are not going to be severe, right? So about maybe 15 to 20% of cases will be severe. And however, even those 15 to 20% of cases that are severe will overwhelm our ICU bed capacity. Now, if you think about it in the United States, the numbers out there are about 100,000 available ICU beds, but about 60% of those are actually occupied. So really, we're talking about 40, maybe 50,000 ICU beds. Hospitals can change the way they run, change ORs, into ICU beds, et cetera, like what's happening in northern Italy. But we would still overwhelm our current ICU bed capacity. On the other hand, if we can put in effective containment policies, which is what we're trying to do aggressively now around this country, and frankly, what places like Singapore and Hong Kong were doing very early on, then what we would expect is the total number of cases would be lower, but also it would take us longer to reach that peak. So the key here is to actually delay the peak of the outbreak so that the number of severe cases that we see are going to be peaking later, and it doesn't overwhelm our healthcare system's ability to deal with all of them. And then that way we're not rationing healthcare. I saw one question earlier about, are patients with congenital heart disease not going to be offered care because they already have problems? And so when the rationing begins, will they be the first ones to go? And obviously, there's no way I can answer a question like that. We certainly wouldn't look at it like that. But the key here is we don't want to get to a point where we have to make any of those decisions. And the only way that we will get to that point is if we delay the peak of this outbreak, as shown in this figure. Next, please. So the American College of Cardiology last week put out clinical guidance for the cardiovascular care team. And I'm just going to go through what the American College of Cardiology is telling your cardiologist to do, okay, for patients who have underlying cardiovascular conditions. So number one, make plans for quickly identifying and isolating cardiovascular patients with COVID-19 symptoms from other patients, including in the ambulatory setting. Number two, patients with underlying cardiovascular disease are at a higher risk for contracting COVID-19 and have a worse prognosis. Now, again, the data that we have is coming from an older patient population, mostly with coronary heart disease. Number three, it is reasonable to advise all cardiovascular patients of the potential increased risk and to encourage additional reasonable precautions in accordance with CDC guidance. So, again, I saw a lot of questions coming about should I stay home from work? Should I not do this? Should I not do that? And in reality, at this point, we're going to have to stick with the CDC recommendations. And I really cannot be, giving you exact recommendations as to what you need to do for your individual condition. But certainly, if people can work from home, if people can practice social distancing, especially those who have more complex forms of congenital heart disease, those with active arrhythmias, those that have had heart failure admissions, et cetera, that is something that I think makes all the sense in the world. It is important for patients with cardiovascular disease to remain current with vaccinations. So this one's important, including pneumococcal vaccine. Now, you may say, well, hold on a second. Why do I need a pneumonia vaccine, a bacterial pneumonia vaccine for COVID-19? Well, the reason to have and be up to date with pneumococcal vaccination is that may be a secondary bacterial infection that may then develop. So it's best that you be protected against that anyway. And also influenza vaccination. Remember, we're also in influenza season here, so stay current with vaccinations. That is important. And then in geographies with active COVID-19, now this is a little bit dated here, okay, because now this is spreading throughout this country. But they say it may be reasonable to substitute telephonic or telehealth visits for in-person routine visits for stable cardiovascular disease patients to avoid possible a COVID-19 infection within the clinic setting. So I can tell you a lot of hospitals, including our hospital at this point, are pushing ahead very quickly with instituting telephonic and telehealth visits for patients. I'm not going to tell you don't show up to your clinic appointments, but I will say please be in touch with your treatment team And many of us at this point are offering our patients the choice of not coming in and us talking to them by telephone or via a Zoom type application. And I think that does make a lot of sense. Now, there are certain patients who need to be seen by their cardiologists, those with active cardiac clinical issues. And in those patients, we may not have a choice, and you may just have to come in to be seen. And then the triaging of COVID-19 patients according to underlying cardiovascular conditions. So this is where it gets a little bit challenging when it comes to our CHD population, because we don't yet have granular enough data to identify which patients should be treated differently from others. However, I do think it makes sense for those with complex conditions, those with active cardiac issues to be treated, frankly, as significantly higher risk than those who are completely fine, who have not had any cardiac issues or any heart failure or any arrhythmias. But that is at this point a personal opinion. Next, please. So what do we do now? So, and you're going to have to help me, Paula, by clicking each of these. So there you go. So if exposed, quarantine 14 days. Or if you have symptoms, fever, cough, viral symptoms. So this is where, please take this very seriously and stay away from others. If clinically stable, then would consider substituting clinic visits with telehealth or telephone visits. And please check with your own providers about this. But that is what we are offering people at this point at UCLA, and many other institutions are doing the same. Like influenza and any other viral condition, proper hand hygiene is important: soap, water, alcohol-based cleaners, etc. Patients with symptoms, when they do enter the clinical area, and frankly, before coming to clinic, you should, and if you have a fever and a cough, you should probably contact the clinic and let them know, because it may not be the best idea for you to actually be showing up to clinic. But certainly, that is a time when we do want patients to wear face masks and be isolated away from other patients. The concern here is many cardiology clinics also have transplant patients there, severely immunocompromised patients. We don't want to put anybody else at risk. So if you are having any issues where you do think that you might have a viral infection, please call and let the clinic know before coming in. Travel considerations and restrictions. My personal opinion is if you do not need to travel, if you do not have to travel, it would be best that you stay put for the time being. That is what I am advising my patients. And I'm personally taking that approach as well, as far as travel. As far as emergency supplies, food, water, toilet paper. So, the toilet paper thing is very frustrating in Los Angeles, where we're completely out of toilet paper. And I sort of want to just stop and tell everybody, hey, listen, this is a respiratory illness, not dysentery. But within reason, please. Hoarding for many months to come while others cannot get basic needs is not a good way to go either. So if an ACHD patient develops fever, cough, shortness of breath, I would recommend that your treatment team be informed. Please stay in touch with your treatment teams. And this is where picking up the telephone and calling is very important. Those of you that are seen at ACHA accredited centers should have 24/7 availability of ACHD providers that you can get a hold of. If patients develop symptoms of chest pain, heart failure, arrhythmias, then likely those patients will need urgent or emergent care. So you don't want to be staying at home and quarantining yourself if you're having severe chest pain, you can hardly breathe, and you're going in and out of arrhythmias. That would be a patient that would require emergency care and very likely hospital admission as well. So although we want people to isolate if there's any signs or symptoms of infection, we also don't want people to take this too far and endanger their own health. And that's, again, where you would need to involve your treatment team. And I think that covers my slides. These are some resources here, some websites that you could go to for up-to-date information on what's happening with COVID-19. Certainly, when we begin getting congenital heart disease specific data, we will try to study that and try to share it, but as of yet, we do not have that. Is Dr. Stout on the call yet, Karen Stout?
Yep.
Okay, so Dr. Stout is the former ACHD director, now the co-chief of cardiology at the University of Washington in Seattle. And our friends in Washington are about a week ahead of the rest of us when it comes to dealing with this pandemic. So I really wanted her to get on the call and let us know a little bit about what's happening on the ground right now in Seattle and what measures are being taken at the University of Washington at this point to protect patients and to protect health providers. Go ahead, Karen.
Thanks, Jamil. So for those of you who aren't familiar with the situation in Washington State, we had a outbreak of COVID in a nursing home that was primarily patients who then were admitted to a local hospital, Evergreen Hospital. And that particular hospital has seen thus far the bulk of COVID-related care, although all of our hospitals have patients and all of our hospitals have seen the spectrum of disease from mild to deaths related to it. I thought Jamil's overview of the cardiac issues really is the same thing that we are trying to educate ourselves. And fundamentally, we literally, in my ACHD clinic today, do not know exactly what to tell adult congenital heart disease patients, but what we've learned from our neighbors across the way, from the hospital who's seen the majority of the COVID-related patients so far, is that the ones who've done most poorly were the ones from the nursing home who had a lot of other medical illnesses. So my approach to our patients has been anybody who's coming into a viral illness where we would be worried about them from the outset, I'm going to be equally worried, if not more so, about this particular disease. But that doesn't necessarily mean that the rest of my patients are perfectly fine and safe, and it doesn't necessarily mean that somebody who has a Fontan physiology or Eisenmenger syndrome is inherently going to assuredly have a terrible outcome. I don't think any of those are true statements yet. We don't know enough to give specific counseling. What has happened here is the social distancing thing, I think, took hold a bit earlier. It took hold both in terms of how people were behaving, but also from mandates from our governor. So our restaurants and bars are all closed. All of the gyms are now closed. Hair salons closed as of midnight tonight. And everything that is essential, that is sort of non-essential, is starting to get shut down. People are actually out. Some places have said that nobody's out for a walk, and that's the one thing that's happening here is there's a lot of folks actually out for walks because the schools have been already closed for 10 days here and are going to be closed until the end of April. And so families are sort of scrambling to figure out, how am I going to take care of my kids, especially for people who can't work from home, and especially when the kids are whacking each other with their iPads and have already gotten themselves bored out of their gourd. And when you're out of school for 6 or 7 weeks minimum, how do you actually educate kids? There's also the influx of people coming back from college because so many of the colleges shut down as of the weekend and sent their college-age kids home. So a lot of what we're doing is actually preparatory. Where we've been spending a lot of our time and energy is anticipating that this week and next, which has sort of started to happen, we're going to see an influx of COVID positive patients. And as Jamil pointed out, the risk of all of this and the reason there is much of a dither is both the individual risk to people, but also the fact that if we overwhelm the healthcare system, then all of the generic healthcare that we normally provide can't be provided because we don't have space, we don't have ICU beds, we don't have providers to take care of people. So we've been trying really hard to set up contingency plans that free up space in the hospital that minimize the infectious risk for patients and that minimize the infectious risk for healthcare providers. And it's not so much just that any given hospital is going to, all hospitals, for example, here, not everybody has a lot of COVID in it yet, but the ones that have a lot of COVID now can't take care of, say, cardiac patients. And so that's where hospitals like ours are starting to step in. But then when we get a lot of COVID patients, how do we handle that? So trying to figure out how to handle a surge of patients for whom we need to support them as best we can. It doesn't have a clear treatment per se. We just need to make sure that we can carry them through the illness while still providing all the care we normally provide is extraordinarily taxing on the system and individuals and is super stressful. And I think that's a lot of what we're seeing up here is we know it's there, we're seeing it, and we expect that there's a tide coming, and it's coming this week and next potentially, and trying to be prepared for that. I think that my take home for everybody is the social distancing is huge. Wash your hands. I'm the snarky jerk who sits in the back of required meetings and says, oh my God, this is so silly that we have to learn this. And I was there with 30 other people learning how to put on our protective equipment and actually going through the here's how you wash your hands. When it becomes something that feels life or death for either you or a loved one, suddenly everybody's super engaged. So go watch the video, wash your hands. Make sure that if you're in some sort of public place, you wash your hands before, you wash your hands after, you do that sort of thing. The value of masks, hoarding a bunch of masks is probably not all that helpful. Washing your hands frequently with soap and water if you don't have gel, and actually soap and water may be even better. If you do it properly, those should work. And I think for people who really have a good solid reason to believe that they may be, we don't know, but maybe at a higher risk or have somebody in their family who's at higher risk of having a bad outcome if they contracted this virus, then yeah, you should kind of stay away from the other humans. We like the other humans most of the time. But in this case, the other humans may be unwittingly, mildly symptomatic and carrying something that you don't want any part of. Our policies through the state of Washington and through our hospital system have not been to ban everybody who tests positive, but to have them isolate if they are symptomatic, because there's some debate as to how much transmission is happening in truly asymptomatic people. But it's also allergy season in addition to flu and virus season. So I've had a bunch of people out, not with COVID, but getting tested. Fever is something that is common in the first, very initial parts of the illness, maybe only 50% of patients. And but as they go along over the ensuing days, most of them get a fever. So that role of checking temperatures is a little tricky. If you have a thermometer, great, but I'm not sure that going out and spending $140 on one, which is what I saw on Amazon yesterday, necessarily seems worthwhile.
So
far,
Karen,
yeah.
if I can hold you there for a second, because
yeah.
We've gotten a number of questions here, specifically
I'm just now
about,
also looking at them. Yeah.
And also, if Dr. Gregson is still on, love his opinion on this. How important is it to check temperature at home? And this is a recurring question. And how often? So Dr. Gregson, maybe, or Dr. Stout first.
I can hop in with what we're doing while we rally Dr. Gregson back on there. I would say that what's happening with the majority, and you guys highlighted this earlier, and I think it's super important. If somebody's got a mild illness, the idea is call your primary care provider's office or your ACHD cardiologist, but primarily call your primary care provider's office to see whether or not you need to be seen. And the majority of people who otherwise wouldn't need to be seen are going to stay home. I think from a practical perspective, what we've had patients around here doing is, check your temperature, because if you're febrile, that's probably a different beast than if you're not in terms of all the different illnesses out there. But really, it's how sick are you that's driving, do you present for care or do you not? And the primary thing is to just really get a good sense of how you're feeling and call in. For healthcare providers, I think it's super tricky for healthcare providers who also have congenital heart disease. And we've been doing a lot of navigating of that. In my particular role of deploying our faculty, I'm trying to be really mindful of people's concomitant risks in deciding, okay, actually, rather than you being the one who's taking care of folks in the ICU, what we're going to have you do instead is cover the echo lab. Do something that kind of maybe keeps them a little bit less direct patient care. And I think for each of you individually, talk to your cardiologist, talk to your primary care provider about how attentive you need to be in terms of things like having a thermometer at home and that sort of thing. But also, if you are working in healthcare or working in other things that put you in contact with a lot of people, what's the best approach for you personally and how should you approach your job, because that's incredibly individualized. Dr. Gregson, back on regarding the thermometers?
Yeah, I mean, I think I agree with what you said, and it seems logical. I mean, look, I'm not too big on measuring your temperature every day. You might notice a lot of the hospitals are moving to screening for temperature prior to admission. Unfortunately, right now, there's not a lot of data on that. There's been some data with, say, dengue virus outbreaks where they did see about a 40% reduction in movement of the disease. But part of the issue with coronavirus, and this can answer some of the questions I saw too, is one of the reasons it has spread much more than the prior coronavirus, like SARS and MERS, is that patients are actually quite infectious prior to the onset of symptoms. And patients can be infectious even in the absence of any symptoms. They may never go on to develop symptoms, but yet they're still infectious. So this has made it a lot more difficult to prevent movement of the virus, and that is why these social distancing maneuvers are incredibly important at this time.
I think for all the complexity of everything we're trying to do up here, to care for what we already have and to be prepared, and UW-Medicine happened to be one of the very early sites that was allowed to do testing in addition to the feds, partly because we had we had it. So in testing, a lot of the folks that have come in and they're sick and they have stuff that sounds awful, and we've gotten them tested, and either they haven't had COVID or they haven't had coronavirus, they've had influenza or they've had RSV, they've had the usual stuff. But that doesn't, they still need to be home. So what we're really adamant about is stuff that's incredibly simple. If you have symptoms, you stay home and you stay away from as many people as you can. And the symptoms can be as simple as runny nose and sore throat, even though that's not the most classic COVID symptoms as reported so far. It can be part of the syndrome, but definitely if you have cough, shortness of breath, they've added muscle aches to that list. And then fevers, there's the value in checking the fever, as perhaps it convinces you that you really are sick enough to stay home, but maybe you didn't need that to convince yourself. Where we have seen value in the fevers is in patients being seen in the emergency department or in being transferred in. One of the things we're struggling with is cardiac patients frequently have shortness of breath as part of their clinical presentation. So when is the shortness of breath part of COVID or something like it, and when is the shortness of breath their heart failure or their congenital heart disease? And in that case, it's not that the absence of a fever is reassuring, it's that the presence of a fever then has them in a different set of precautions than we might use otherwise. And a lot of the precautions end up being a big deal once you actually come into a hospital or you're being transferred into a hospital. Being able to start getting testing and turn it around. So if somebody does have a fever and shortness of breath and a cough and know that it's not COVID can actually influence a little bit how we might handle some of their care. But in general, if you got the crud, stay home. And even if it's really mild, and even if you're not entirely sure if it's your allergies or not, then just stay home. And for all the people who are asking, should I just stay home or just go live my life the way I normally would? I've always been a big advocate of go live your life the way you normally would, but not with this. This stay home if you don't have to be at work. I have given all of our faculty and all of our staff, their division staff, and everybody have been given the fairly explicit statement. If you can do your work from home and you do not have to come in, please do not come in. Just stay home. When you have to come in, do so. But when you don't. And do this. It's this hope. This is going to be for a while, but it's not going to be forever. And in the meantime, if we can just cut down on the spread of the thing, we ought to be able to allow, hopefully, fewer bad outcomes, allow the healthcare system to function at a reasonable level, and not have the thing inundate the place. Italy is a warning sign for sure. When we talk to the Italians, it sounds absolutely awful. The South Korean experience looks to be a better one. So I think social distancing, even more than quarantines, it's a big deal. We don't have the choice to go out to restaurants anymore, but going out to bars and that sort of thing of I'm just going to do it is probably not the world's best idea at this stage of the game. I've got so many people around me saying this seems like much ado about nothing, and I fear that in the next couple of weeks it'll be fairly obvious that it wasn't.
So, sorry, we just have a few minutes left, and I'm thinking we should hit some of the major themes of the questions here. We now have over 340 questions, but in reality, we won't be able to answer them. But some major themes. Dr. Gregson, does coronavirus last in the air, and would it be safe for people to go for walks, run, or hike. So essentially, I think this is a question for how long does coronavirus live on and remain infectious on surfaces or within the air. Can you give us an idea of that?
Yeah, so there was a slide in my presentation early on about how it's transmitted. It's transmitted by droplets rather than airborne particles. So droplets are very small particles that come out of the mouth and contain the infectious virus in it, and these fall quickly to the ground due to their weight, typically 3 feet or so in a normal, say, conversation with somebody. But we're saying 6 to 9 feet, particularly if somebody sneezes or is coughing, they can travel further. So that's why they're saying the social distancing is so important. And there's a wonderful video on Twitter that shows Italians waiting in line at a drugstore that's recently received masks, and everyone is about 3 meters from one another down the block waiting. It's incredible. And so I think that's fine. And walking the dog around the block, going for a hike in the mountains, you're not in a crowded environment, that seems perfectly fine. Leaving, so it does persist on inanimate objects. The infectivity of that is not really known. I'm not sure it's known how many infectious particles you actually need and in what route to become infected. There are some early studies with the SARS and MERS coronaviruses. They show that on objects such as plastic and cardboard, they can last up to 4 or 5 days. Most of the studies that looked like shorter, about 24 to 48 hours, they mentioned 9 days. There's one study that showed 9 days, but that was in a suspension, such as a fluid. So I think for objects such as toys you're getting from China or food you're getting from the market, that's inaccurate.
So Aric, a related question is how confident are we that if we eat food that someone else handled, there is no risk? That's one of the questions. So can you talk a little bit about the handling of food and the potential infectivity if those that are making the food or handling the food do have an infection and those droplets do end up on your takeout?
Well, that is an unknown, I will say. If you're preparing your food yourself, you wash your hands before and after preparation of the food, and if you cook it, clearly that's going to deactivate the virus. Whether your food that is prepared for takeout and has virus on it is infectious, I don't know, to be honest with you. There's no studies I found looking at actually persistence on food and infectivity rates of eating such infected foods. I would be more concerned maybe about the packaging that the food comes in, so maybe unpackage and then wash your hands prior to serving it.
So another question or sort of line of questioning that I've seen here is for those that have prosthetic valves, people are asking, does the coronavirus cause further narrowing or dysfunction of prosthetic valves? And I think I can answer that one to say that, yeah, viruses typically will not cause or do not cause infective endocarditis the way bacteria or fungi would, and so they should not affect the function of your valve. Another question that keeps coming up, and Paula, maybe you can address this one, is will the slides be available afterwards and how can people get them? And a recording of this webinar. Paula, do you want to say something about that?
Yes, the webinar is being recorded, and it will be available on our website tomorrow. It's also being streamed on YouTube, and so it will be on our YouTube channel at all times, even after we stop the webinar tonight. So just watch our Facebook page tomorrow for an announcement that the webinar is live, or just go to our website and you can search webinars and it will take you to a page, and if the webinar is up, it will show you that.
Can I ask Jamil one more question, maybe Dr. Stout? I realize trying to keep patients at home and when they're sick, stay home. But what is there something in particular that would drive you to suggest that they call their primary or come to the hospital?
What we've been doing, and what our primary care. Oh, sorry, Jamil, you want to go first?
No, please go ahead. Go ahead, Karen.
So our primary care clinics are obviously getting a lot of this, and so we've been navigating this with primary care clinics and with our clinics and our patients. So people who have any of those infectious symptoms particularly if they're worried. I mean, it's pretty easy to call and just say, hey, here's what's going on, what should I do? If kind of people look at it and say, wow, I feel really miserable, I would normally go to the doctor for this, then that's what you should do. But you should call first to find out whether you're going to go to your primary care provider's office or if you're going to go into the emergency room. Because in many of the cases, our primary care providers will identify up front that somebody's going to be better suited to the emergency room. Once testing gets a little bit more available, there may be value. We have it in some places here. So people, we've suggested, okay, well, you have a cough, you have a fever, you have something that sounds like it could be COVID. It also could be influenza, and it could just be usual colds. Why don't you call your PCP's office? And the PCPs may have them come in, get vital signs checked and everything else. If they're feeling pretty punky, get tested and then go home and then await test results. And it's not like the test results explicitly change how people think about it, but it does for those of us who are healthcare workers. At least our policies here are if you have standard upper respiratory infectious symptoms, you can go back to work 24 hours after you are completely symptom-free in terms of no runny nose, no cough, or no significant cough, and no fevers without Tylenol after 24 hours. But if you have tested positive for COVID and you're asymptomatic, you have to wait 3 days. So there is some impact on return to work for healthcare providers that may be valuable from a testing perspective. But otherwise, we've been saying anything that would otherwise drive you to call your doc, do it. And if you're worried or you're trying to figure out how to go back to work or what limitations you should place on yourself, I think that's a reasonable phone call as well. Yeah. Okay. And if you're feeling super crappy, you should go to the ER.
Yeah, there's a related line of questioning that has come up over and over here, which is that some of the folks on the webinar, listening to the webinar and watching right now, have congenital heart disease themselves or possibly children with congenital heart disease as well, and they are healthcare workers. So what advice would you have, Karen, for patients with congenital heart disease who are also healthcare workers? Any thoughts about that?
So I have a lot of I have some of those, but I also just have a whole faculty. You've got 140 of us that have a whole range of medical illnesses that may either they or they've got a family member at home. So what I've done and what I think the best we can say right now is that sort of thing needs to be individualized. There are definitely people for whom their job has them doing primary, direct patient care, but there are alternatives of something else they could do that would minimize that. And I might take somebody who's got really significant complex congenital heart disease and say, you know what, now's not the time to be directly taking care of patients when you can avoid it. And if they are working with me, then I'm going to try to assign them to things that are going to be a lower risk, perhaps, than not. So is it going to be up in the actual COVID positive patient rooms? No. Is it going to be in an urgent care setting where you have no idea what's coming through? Yeah, probably not. So for people who have that opportunity, I would sit down and talk with whomever's doing the scheduling, whomever's planning. Because the other flip side of this that makes it tough for healthcare providers is, we're on the front lines of this thing this time. Different groups get to do the front lines, and this time it's ours. And so we want to help out our patients. We want to help out our partners. We want to help out just society on the whole. And if we've got a skill that we can offer, we want to offer it. But we want to do that balancing the risk to ourselves and our families. And so I think an individualized conversation about how do you do that within the context of what's going on right now. So I've done that with our group of saying, I'm going to need help. If we have 30 or 40% of our workforce out because they're sick, or if we get utterly swamped with cardiac patients that can't be seen somewhere else, then I'm going to need extra bodies. So how do I deploy them? Not everything has to be directly in the line of fire, as it were. And then in the meantime, just all doing the hand washing and all the other good self-care measures. And for the people who have absolutely no choice, they're anesthesiologists or they are ER docs, I think that's a good conversation to have with your ACHD cardiologist and primary care provider to try to decide how best to approach that, where you're in some sort of subspecialty, or if you're a nurse who's in urgent care, which is something that I was dealing with earlier today, how do you balance the risk of something where you're going to have kind of uncontrolled exposures?
Yeah. So we've now gone an hour and 35 minutes. So just to wrap it up here, Paula, folks are asking if you don't mind stating again how people can get access to the webinar recording later. They would like to share it with others. So if you don't mind just letting them know about that, and then
Sure.
We'll finish up. Thank you.
Okie dokie, thank you very much. So everybody, the webinar will be on the ACHA heart.org website tomorrow. If you check either the webpage or the Facebook or Twitter page or Instagram page, there will be a post as soon as it is up. It takes a while to process that and to get it uploaded to the website. If you have questions about it and you can't find it, you will be getting, if you're on this webinar, not on YouTube, but if you're watching on this webinar on Zoom, you will be getting an email from me late tomorrow afternoon that will have the link in it, okay? So it's very simple. You can also, if you cannot find it, feel free to email me. I'll just give you a simple email address that I look at, and that's webinars@achaheart.org. I will look at all of those emails, and I'll send you the direct link if you can't find it. So I just want to take this opportunity in closing to say a very big thank you to our healthcare provider team who gave their time tonight, or actually this afternoon if you're on the West Coast, tonight if you're on the East Coast, to do this webinar for us. Basically, this has just sort of popped in our environment in the last, really seriously, over the country in the last week. And we've put it together since late last week, and we are so appreciative from the Adult Congenital Heart Association to Dr. Gregson, Dr. Aboulhosn, and to Dr. Stout for coming on and helping us all understand a little bit better about COVID-19. Thank you all for coming. We've had a huge response, and I think we've had close to 3,000 people on both of our venues tonight. We'll let you know if you're interested. Let me just say a couple other things as we're closing up. You will get the opportunity to evaluate this webinar, and as you close out this window, you should get a pop-up on your computer. There are just 5 questions, basically, and a place for comments. We would really appreciate your feedback. It takes maybe 2 minutes to complete. If you don't get to it tonight, you'll get, again, in the email tomorrow, it'll have the direct link to the webinar. And we'll share these with our presenters as well as with us to make our webinar series better. We are having another webinar. It was pre-planned, just coincidentally. It's stress management in ACHD, a balancing act. Just happened to be on our calendar for next week, Thursday night, March 26th. It's going to be done by Dr. Kristen Fox, and she's a postdoctoral scientist at Nationwide Children's Hospital, working with Jamie Jackson, who is a psychologist who works with us in the adult congenital heart world. And I've spoken with them today, and they are going to change their focus to talk about some of the ramifications psychologically of COVID-19, because those of us who are on this call are clearly concerned, and it does come with a lot of stress in all areas, including health, financial, child care, what are we going to do with our children? And that list just goes on and on and on. How are we going to get food? What about my medication? So there are a lot of stress factors. So go on our website. That's open for registration. The link, again, will be in that letter you get tomorrow. So let me conclude. I know we've gone over time. I think we have close to 1,000 people still hanging in there with us on the Zoom, and I appreciate that. We appreciate you coming, and looking forward to seeing everybody at next week's webinar. Thanks again to the docs for the time they've given us tonight. Appreciate it. Good night, everybody. Have a good evening.
Thank you so much, Paul.